Coming from India, it's a low and middle income country, and that is why during COVID time and even before that, where patients are unable to access rehabilitation, stroke rehabilitation in a tertiary care center or in a secondary healthcare center, it's very difficult in countries like ours. So our interest in tele-rehab had begun much before COVID. And COVID, in fact, enhanced the interest. And we've got a certain guidelines, clinical practice guidelines for tele-rehab now in the country. However, there is a lot of differences between the high-income and low-income countries. With respect to evidence, I would say there's a lot of evidence from the high-income countries which cannot directly be applied in a low-income or a low and middle-income setting like ours. We have issues like policy barriers, legal issues, data privacy issues, which even a high-income country has. In addition, a low-income country would also have the issues of awareness, right from the patient side, the caregiver side, as well as the therapist and a neurologist side. There are issues right at the foundational level where we do not have referrals coming in from neurologists to a rehab person at an early stage. So we are tackling a lot of these issues. The second major issue that low-income countries specifically have is with respect to assessing, using standardized assessment tools for assessing the function of a patient and impairment, sensorimotor impairment of the patient, which is unlike in the high-income countries. So that is where we are at, and a little bit of this will be discussed in my lecture as well. So interestingly, we have a socially, culturally specific, and I would say region-specific smartphone app that we are building in our institution here in collaboration with a bioengineering department in southern India and also IT information specialists on our board. So we have a consumer voice included there as well. So different parts, different stakeholders of the community have taken part in developing this smartphone app, which is going to target treatment of sensorimotor impairments post-stroke. This would allow not just delivering intervention remotely, but also assessing their progress over 8 months' time post-stroke, which is very, very crucial. If you have read about the ATTEND trial, it stated that a supervised rehabilitation program is a necessity. In the ATTEND trial, which was found to be neutral, sadly, the supervision stopped around 2 months after discharge, and that is why our patients did not show comparative improvement when compared to the control group. And so that is what we are targeting right now, prolonged duration of supervision, as well as modifying the rehabilitation goals through this app as per the patient's need, because stroke picture keeps changing with respect to what the patient needs, how his sensorimotor goals have been achieved over a period of time. So that is the one thing that we are working with right now. The second important and very interesting thing that we are working with is an indigenously built robotic system, which has cut down costs almost by 70%. And is giving us almost a similar number of repetitions. Sorry about the background noise. It's giving us enough number of repetitions that even a high-income country robotic system may give you. And repetitions is very essential for a motor program to be built in stroke. So those are the two interesting things we're working on now. We're waiting to do so much more.